live stream the Ministry of Health. This is good now. Hati, how do we? It's good. It's even clearer. Katkozabaro OLC5 abana
So open your audio max with the saving.
ubunyanga bwize turakora
It is even still yes. Can we start?
Begin with prayer, then introductions and tea. By 11, when the minister comes, when people have finished.
Good morning once again. We'll start our program. We have wasted enough of time. We have a prayer. I know within us we have invited the religious leaders, the health coordinators of the religious denominations, because we're expecting Father George for the Catholics, Father Sarah for the Measles-Rubella, a coordinator from the SDA Church, a coordinator from the Born Again.
Is the MOH page also streaming? YouTube.
Muslim.
Is the MOH YouTube
So we
page
have
also
a prayer,
streaming?
then we do self-introduction, we go for tea. Now, without wasting time, we want to invite Pastor Elijah. He's the health coordinator for the Born Again to give us a prayer. Then we do self-introduction. And then we go for tea. As the minister comes in, we shall start our program with anthems.
61% of recipients
Then
have
we get
opened
marks.
this.
We have the marks from the city health officer
We have
or
opened.
the representative. We have the state mayor.
And then read.
If he's not in the house, by that time, any LOC firm that is around from the invaded districts will give remarks. Then we proceed with our program as will be mentioned. Pastor, give us a prayer.
Let's have ourselves and then we pray from where we are. Father God, we just want to thank you this wonderful time. We thank you for this workshop. We thank you for the people who have been invited here and officials from Kampala, from different sectors, from different organizations that have come here to get more issues and learn more about immunization. Father, we pray and we declare, we commit this workshop to your presence, that everything we learn this morning may be paramount to our spirit and to our souls. Father, also with the cake and the breakfast that we're going to take, that they give us more energy to work and we glorify your name. Father, we pray in the name of Jesus Christ. Let everybody say,
Amen.
God bless you. I'm Reverend Mr. from Fort Portal, Pentecostal Church. I'm the health coordinator for the Born Again Pentecostal Church in Fort Portal. May God bless you.
Thank you, Pastor Elijah Mbisa, for the prayer.
I'm Pastor Sam President, health coordinator, Midwest and Granfield, SDA Church from Kambote P. Most welcome.
Good morning, everybody. I'm Mubabas Justin, a community health worker working with the Hope Health Center 4.
Good morning, everybody. I'm Kadura Lois from the Hope Health Center 4 Community Health.
Praise God. I'm coordinator Coronessa Ochak, Community Health Worker, Central Division.
I'm called Ajoina Asha from Rungaji Sub-County. I'm working with the Good Health Center 3. Thank you.
I'm Chairman Richard from Uganda Council. I'm working as a health community worker, at the same time expert client. Thank you.
God is good. I'm Business Clovis, VHT coordinator, Chama Sub-County, Chama Health Center 3.
Yes, good morning, everyone. I'm Mr. Joseph from Tampa Meeting.
Good morning to everyone. I'm Rangamande from Polytechnic, Dubai, from Church Health.
Good morning, everyone. Dr. B. Christopher is the DSO for Project. Good morning to you all. Dr. Kahuma Frederick, DHO Toronto.
Morning, everyone. Adolf Sims is my name, and I'm representing ADHO MCH, Kianjojo.
Good morning, everyone. I'm Joseph Mwambisha for DHD Children District.
Morning, everyone. I'm Sabit Steven, Chairperson of Power Market from Progress.
My name is Kawo Ed. I'm the district vice chairperson of Lucifer.
Good morning. My name is Julius Wamro. I'm representing the city health officer with model device. Welcome.
My name is Mr. Frank from Karambi, attached to Karambi Center 3.
Good morning, members. My name is Namara Brian, Health Inspector, Kichwamba Sub-County, Kichwamba Health Center 3.
Good morning, everyone. I'm Catherine Kemgawati. I'm the district health educator for Kabarodi. Thank you for coming. Thank you for having us.
Good morning, everyone. I'm Consideration, a health assistant working with Bototo City.
Good morning, Brenda Yemare, Health Inspector, Bototo City Council. Morning, everyone. Kasemiri Fon is my name. I'm a health assistant for Bototo City.
Morning, everyone. I'm Wamusha Richard, a community worker for Bototo City.
Nakoto Francis, Antigens worker, Tetanus-Diphtheria Center 4.
Morning, everyone.
Let me go to the reception and have it.
Morning, I'm Charles Bukantwa, the Prime Minister of the Babomba, Odujo.
Morning, everyone. I'm Wabola William, Chairman, Carol District Association.
Good morning, everyone. My name is Amir Wambani, Health Inspector, Kichwamba Council, Kabarole District.
Yes, good morning, everyone. My name is Lucia Kahule. I'm the acting ACHO in charge of environmental health for Bototo City.
Good morning, ladies and gentlemen. I'm Bridget Kawahenda, a journalist working with UBC.
Good morning, my name is Nyakoma Ali, working with the 42P.
Good morning, everyone. I'm Birun Zura, Health Assistant and Group Subcommittee at the Bototo Center.
Good morning, everyone. Editor Trilojuni. I'm here on behalf of the Program Manager, Beira Uganda. Nice to meet you. Good morning, everyone. My name is Anna Tahirwa, ADHO, Judge of Maternal and Child Health, Kairo District. Thank you.
Good morning, Lucy Kawasinguzi. I'm the acting ADHMCH. You're welcome.
Good morning. Tony Mugisa. I'm a lecturer and I'm a trainer with Ministry of Health in Nepi. I'm here for the regional coordinator in Nepi.
Good morning. My name is Wilson Rudy. I'm the acting ADHMCH for Kiambu District.
I greet you in the name of our Lord Jesus Christ. Gahanga Patrick is in the name of the district service delegate at Tuko District.
Good morning, ladies and gentlemen. I'm senior citizen of Israel and the elder from OPR, Tuko District.
Good morning, everyone. I'm Kizweta from Ministry of Health.
Good morning, ladies and gentlemen. My name is Gerard Musime. I'm a program officer specialist at Ministry of Health.
Good morning, everyone. I'm Mariam Halukenge from PATH.
Good morning, ladies and gentlemen. My name is Dewa. I work with the PATH team as a senior program manager and also trying to fit the shoes of our country director who is not able to be here with us. Thank you.
Yes, good morning, everyone. I'm Cyrus Mzee Marambi, Deputy Analyst in the law.
Good morning, everyone. I'm Jerome Kenneth Riondo, representing the tax operators.
Yes, good morning, everyone. My name is Philip Katabaro, and I'm from the Ministry of Health and the Health Promotion Department.
Good morning. My name is Joshua Mpoy. I work with the Regional Referral Hospital and the Regional Emergency Operations Center. Thank you.
Good morning, ladies and gentlemen. Edward Kajawa is my name from Ministry of Health, National Malaria Elimination Division. Thank you.
Good morning, everyone. My name is Saul Olgembe. I work with Baylor, Uganda, and I'm here on behalf of communications. Thank you.
Good morning, everyone. Stephen Onega is my name. I work with Baylor, Uganda.
Good morning, ladies and gentlemen. My name is Presi Chikoye. I work with PATH. Thank you.
Good morning, ladies and gentlemen. My name is Akai Faith. I work with Baylor, Uganda.
Good morning, everyone. My name is Dr. Wahizi, Archibald Newton Serahine. I'm the Senior Executive Consultant for Portland Regional Referral Hospital. I'm also representing the Commissioner Reproductive Health.
Thank you, Doctor. You're welcome. Our tea is ready. We shall be read by the director. Our tea is ready. Yes, how many minutes should we take? 20? If we can do 20 minutes, latest 30 minutes, please. Our tea is ready. Our tea is ready. We are not being served.
This one's.
It is telling me you're still in introductions.
Hey, now. Introduction, good people are taking tip.
You first move on the side. You're blocking my view.
So whoever drops out,
Let me ask Kajova.
once you see the presentations, the next presentations after the director has opened. I'm going to try to put this projector here and I see whether it shows from.
Okay, you blocked, or during introductions, you blocked all my people.
Sure.
You should stand on the outside.
Where was I standing? I thought I was moving the microphone. I thought I was moving the microphone.
Yeah, but move on the outside, not inside the circle. Yes, you were moving inside, but you were holding a mic, but you should have gone out. I wanted to alert you that the camera is here. So when you're moving, move on this side.
Outside.
Hey, outside.
The outside. Now if I'm taking the microphone to someone.
Yeah, you can pass, but when you reach there, just
give and move.
Stand in a way that you can see this, that it's capturing the person. In a way that it is not, you're not blocking the person who has the mic. The focus is this one. So make a way for.
I move away from this one.
Just make a way for this one. Yeah. Deo, is this good?
Since I'm coming back. She has.
Let me get him. Let me get his number.
It's okay. It's not an anomaly. This content is for God and my country should have been here because this is where the speech ends. So she might turn thinking she's continuing.
Naza kuba yakirebera.
Maybe
when we give it her,
and she will see
she
where
will
it's
quickly
ending. Okay, great.
peruse through and know.
Is SWX in caps? It is 65.
Password is this one. Big S.
Malaria ikachendera. Like, at least we have
Who is a Zoom?
Colleagues, we're getting back to our program. You can see a great number that are done with the tea outside. I request we get back and resume our program. We can as well have a working tea. You can carry your cup and then you start. Colleagues, those are out. We are kindly carry your cups and resume our program. Kindly carry your cups. On our program, after the minister has arrived, we shall have anthems. We have already prayed. We are expecting the Minister of State for Permanent Care, Honorable Margaret Gisam-Anga, to be with us, and some ministry officials that will accompany her. We're also expecting the Chairperson of the Service Commission, the former DG, Dr. Henry Mivesi, to be with us. After the anthem, we shall have welcoming remarks from the City Health Officer. Will be followed by, we expected the City Mayor, but we have agreed that any chairperson of the district that have been invited will be in that position. Then we shall have remarks and meeting objectives by the Senior Executive Director for both Regional and Foreign Hospital. At the same time, is representing the Commissioner on Reproductive Health, Dr. Mgai Richard. We shall have malaria vaccination introduction presentation by Dr. Ramakosa Jane from the Ministry of Health. We shall have remarks from the Chairperson Service Commission. I mentioned that, Dr. Henry Mivesi. Then we shall have keynote speaker from our chief guest, who is the Minister of State for Primary Care. We shall have a panel discussion. I'm sure those that are going to take part in the panel are already aware. They are already aware of what we're going to discuss. Our panel will sit up here, and I will tell you later on, I will tell you how many minutes were given each of you. And then after the panel discussion, actually the panel shall have Dr. Richard Obeti, the DHO in Nyagabu district. We're expecting the LC5. We are expecting the LC5 Kenjojo, Honorable Omehayo. We are also expecting the DHE Kalorade, Teddy Catherine. We are expecting the MCH, ADHO MCH district, Rudy Wilson. The Minister, Cultural Health Minister, I'm sure is also informed. And then from Hajj Ray Kayolo Bashir for the religious leaders. Everyone has gotten the questions. You get to know how long, what time that has been allocated to each of you. Thank you. Colleagues, I think we resume. As we're waiting for the minister, we can do other things. We know ministers are always very busy. Actually, we always want to find. Without wasting time, I want to invite the CHO to give remarks. Not officially when the minister comes in, but let's do other things. We can't wait longer. Julius, you're welcome on behalf of the City Health Officer. And as Julius is coming, we expect to have RBCs and RCC, LC5s and Mayor, COW and the State Clerk, DHOs of the 4 districts and the CHO of Fort Portal City, ACHOs, MCH, Assistant DHOs and Assistant CHO, Maternal and Child Health, District Health Educators and the State Health Educator, cultural leaders. We expect to have a Prime Minister and a Minister of Health of the 3 cultural institutions, Toro Kingdom, of Dingia Wabamba, and of Singa Walozuru. Our media institutions, all that are here, both TVs and the radios, all of them are invited. Business community, they're already here. We have the chairpersons of the markets, we have the chairpersons of the taxi drivers. The ministry had a reason to invite such people because they serve a very big area, and it is very important on what we're going to talk today. The other side of the technical, we have health inspectors and assistants. We also have our community health workers, our VHTs. So without wasting time, this shall be on this protocol. I kindly request the next speakers not to repeat the protocol. Thank you.
Thank you very much, Stephen. You made my work simple. Good morning, everyone. Protocol has already been said. Once again, my name is Julius Wangrom. I'm the logistics spokesperson for this city, but I'm standing in here for the city health officer who is not with us. He's in other engagements. I want to warmly welcome you all to this beautiful city, Fort Portal City. It's a good city and a hospitable city. This engagement, as you can see, is going to look at the importance of immunization in protecting our children, families, and livelihood. And as you are aware, immunization has done wonders in our country. We have had so many emerging diseases. The point case in point is COVID-19. When they introduced the immunization, COVID declined, and now we are here. So in this engagement, I expect to hear a lot about malaria and how we can include malaria in our routine immunization. We have had the experience COVID-19 and yellow fever already included in our routine immunization, and it has worked. So my expectation as a technical person is very high. I know we shall achieve, but I want to thank God first, because this is His way of doing things. God gives us wisdom and uses humans to bring such innovations. So at this time, we want to appreciate our partners. Gavi, a World Health Organization, UNICEF, and others. They've done a lot to see that this vaccine is in place. We are aware that malaria has done us so much bad. It has caused a lot of death, especially the under 5s. And as we talk, you find 1 or 2 people already hospitalized because of malaria. So without wasting time, I want to invite you to actively listen and harness this opportunity and promote malaria prevention. And thank you.
Thank you, Julius Sambo, on behalf of the City Health Officer. Dr. Solomon Asim sends greetings, but due to other engagements, we are here. The office of the CHO can never be alone. Without wasting time, we want to invite the LC5 Munyangabo, Honorable Tegeka James Mugaraba Intade. Akichi, we welcome you. Then we come and give remarks. We don't have morale, we will clap and welcome them. Because when they mention Intade, you know what it means. Yes.
Thank you very much, my good friend and moderator, Kalari Ichum, religious leaders here present, the resident district commissioners here present, the district chairpersons, all their representatives here present, the cultural leaders here present. I've seen some of them. The chief administrative officers, the DHOs here present, staff from the Ministry of Health here present, our partners here present, and the press. I've seen members of the press here present, and all distinguished participants. James Ategeka Mugarama is my name, and by the grace of God, I'm the district chairperson, Wenyangao. I want to thank you all for coming, and I also want to thank the organizers of this very important engagement, the half-day engagement, Ministry of Health, and the partners. I want to thank you very much for inviting us, and more so as the political leaders. I want to thank you, and thank you very much. Today is an important day because we are discussing the most important, the crucial issues affecting our people, and more so health. And mainly malaria. Malaria has continued to be the leading killer disease in Uganda. And yet, the government has put a lot of money in the fight against malaria. But despite that, it has continued to be the leading killer. And it takes almost a quarter of Ministry of Health budget, yet it continues to kill our people. Government has made many interventions. You remember, not long ago, we were given nets, and they reached all of us. But it's very unfortunate. People are using them for different purposes. Some of them use them as breeding nets for breeding for birds, poultry. They use them in gardens for breeding, I don't know, beds, nursery beds, and many other issues. Others use them as ropes for tying goats and other animals. So I don't know, this should be a concerted effort. We should join together, all of us. And we have the right people in this room. The cultural leaders are here. The religious leaders are here. The technical people are here. The chief administrative officers are here. The RDCs are here. The political leaders are here. Why don't we join hands and fight all these challenges that are affecting us in other countries like America, China, and the others? You don't hear about malaria. It is not there. It is not there. In fact, if I remember one of the citizens of America visited Brazil and died of malaria. It was a national concern. Brazil discussed in their parliament because one of them had died of malaria. So it is easy to fight malaria. If we all join hands, honestly, we can fight. If you go to all these health centers, the most cases that are reported there is malaria. So, dear participants, let us join hands. For us, as political leaders, we pledge commitment. We will work hand in hand. And if the budgets also allow in the future, if we can collect more revenue as local leaders, we can also add our budgets to win the fight against malaria. But for us, we are going to play our part. We are going to sensitize the masses. We are going to sensitize the masses. We are going to educate them on various issues, the importance of nets. We have been teaching them, we have been sensitizing them, but of course it takes long. You have to say it as many times as possible for somebody to grasp it. So we pledge that commitment to sensitize our masses. We also call upon all of you to also join hands in the fight against malaria. The other diseases are also there. Hepatitis B. It is unfortunate that hepatitis B was used to kill people in Uganda today, despite the vaccines. In most of our health centers, if I'm not mistaken, we all have these vaccines. But very few people know about these vaccines, that HPV is there. They don't know that we have hepatitis B vaccines. And if it is there, and if people come for them, they only take one dose, they don't take other doses. Doesn't work. So let us join hands to sensitize our people. But we fight against these diseases, these killer diseases. It is easy if we join hands, we can eradicate them. Otherwise, we have no option, ladies and gentlemen. We have no option. These vaccines, we have to take them. We have not made our own vaccines. Even if we tell people that please, the white man wants to kill us and the other. But we have no option of doing, we have not made our own vaccines. We'll continue using them. And I don't think they want to kill us. If they so wanted, they would have eliminated us long time ago, using other means, even without vaccines. So let us sensitize our people. The religious leaders are here. The cultural leaders are here. Let us tell our people, these vaccines are safe.
Because since we started using polio vaccines, polio has indeed been reduced to a sustainable percentage. Malaria now, when we use these vaccines properly, I know it will be reduced, and this will affect all other spheres of the economy because it touches everything. Politically, our people die of malaria. We lose voters. Economically, the country is losing a lot of money. Socially, we are losing our people. So it is imperative that we all of us join hands in the fight against all these killer diseases. Once again, commend the Ministry of Health, our partners, despite the challenges at the international scene, we are continuing to work with them. But as leaders, let us also look for alternative means. Minus the donors, can't we also work? I've heard of Tanzania under the late John Pombe Magufuli. These people were not using donor funds. They had totally reduced some extent. So it's a question of planning. We can continue sustaining ourselves. Government can decide to work with these existing NGOs, CBOs and the others, and we continue supporting our programs. But because of other issues which I may not discuss now, corruption and the others, we cannot sustain them. Otherwise, we are collecting a lot of money. Collecting a lot of money in terms of local revenue. And if we are also tap those who are not paying taxes, I very well know we can handle this despite if the donors pulled out, we can continue operating without the donors. But now, for now, let us continue praying that the donors remain. We remain working with them. Otherwise, we can also continue working without them. The question is sustainability. Members will have failed to sustain things. Me, I'm a live example because they came in leadership during the times of Bail with their flagship program of saving lives. These people gave us border ambulances, and all of us were given all districts, but they're not working. Why? Because we failed to sustain them. We should learn how to sustain programs. Despite the closure of these programs, we should continue. We always have workshops like this to only plan about sustainability. But in the end, we failed to sustain. We had the nutrition project, which was a very good project in schools. Have we sustained it? Have we restored what we need? Potato leaves, potato stems, some iron-rich beans and the others. But we also want the donor to continue giving us those. Yet, we can provide them without the donor's support. But because we have that now, the mindset, and you know the standard measure of the mind. The standard measure of the mind is the mind. So if we continue with that mind of the donor will come in, you find even some of the technical people here. I normally see mine there when there is circumcision, female circumcision, because everybody circumcises at 20. They highly participate in it. But if it is not at 20 of circumcision, then they don't attend them. So members, let us learn to work even when there is no money. Because at least now you, the scientists, at least you have something which is tangible. Even when there is no other these programs, or you can continue operating. So my prayer is, with or without facilitation, we can still operate. We can still work. We can still continue with these programs. We can still sustain, even without even being given facilitation to go out in the field. We can still sustain, even without being given extensions, outreach funds. You can still move. Now the government has done its best. It gives us at least some money to run these health centers. You can get something small for somebody to go out and vaccinate, immunize, and also sensitize the public. We have these PhDs. Let us incorporate them in these programs so that we can have a bigger, a wider coverage. With those few remarks, I want to thank again Ministry of Health and the donors for supporting us, and more so for inviting us. I think I've been given the opportunity to officially open this very important half day.
engagement. May I now take the word to officially open this half-day engagement. Thank you.
Thank you, Chair. That is not enough clap. I think I give an organized one.
Let's give an organized one to our entire. You know what entire means? Lion. And you think a lion is a small thing? Now let's give 100%. When I say 100%, you clap as if you have seen the lion. Yes, 100%.
Thank you. Thank you, Chair. We want to recognize and welcome the colleagues that have joined us when the chairperson was giving the remarks. So you're highly welcome. On a special note, we want to welcome Dr. Jane Namakosa from the Ministry of Health. Doctor, you can wave to us. Yes, that is Dr. Jane Namakosa, and she will be presenting something here when they come. Without wasting time, I want to invite the assistant RDC Drogo to give their remarks, but let's be mindful of time. Maybe the RDC Drogo. After we shall invite the senior executive consultant. You know, those are new titles. Yes, we used to know the director, the like this and that, the consultant, now it's senior. They are not called, this gynecologist, we've been calling gynecologists and we call them senior consultant, assistant, executive. Thank you, RDC.
Thank you so much. Assalamu alaikum. God is good. And all the time. That's good. I had my sister there saying that when a lion is coming, when you're appreciating the lion, you have to clap. The lion is one of the most feared animals. So I don't know whether you can clap at it when it is. Okay, nevertheless, I wish to welcome you all and thank you for coming here for this wonderful moment. I don't have much to say, only to emphasize what my comrade has just said here, to thank the organizers and these partners of ours for done a tremendous work. The Ministry of Health, thank you so much. More so, our lovely government, NRM, for the prevailing peace and atmosphere for all this to happen. We all know now, as we speak in Congo, you cannot have this. As we speak in South Sudan, people cannot sit like this. So, the NRM government, with the leadership of our president, we really thank for this atmosphere. Well, health is wealth, as we all know. So if there is any attempt to minimize or to curb up anything to do with something that can disrupt health, then we all have to come and join hands and fight it. It is a collective responsibility for all of us. It matters to all of us. If we don't and leave it to other people, people say, Ministry of Health will handle, it is not enough. It is a collective responsibility. I just want to add my voice to everyone who thinks that health matters. Let's be together and fight all this. It's good all the stakeholders are here, those who have not come, at least the message will reach them and see how we can build our country. A country with all these sicknesses cannot move ahead. In the interest of time, allow me to wish you the best deliberation. And if time comes for going back home, we shall pray for the Lord to take us back where we came from safely. Thank you so much.
Thank you.
Everyone will give him asante sana.
Thank you. I really hope the lion has not had. Thank you, Bwana RCC. I want to invite the Senior Executive Consultant for Total Regional Referral Hospital, who has put on 2 courts, also the court of the Commissioner on Reproductive Health Uganda. Dr. Archibald Bahizi, you're welcome.
You have to use
The IT will find us on the way. Okay.
I think the battery is off.
So, good morning, everyone. I hope it's still morning. So, I want to, I introduced myself, but those who are aware, my name is Dr. Bahizi Archibald Newton Sebahiri. That is my name. And this morning I'm going to speak in two in one. I'm going to give remarks as myself and also share the objectives of this session on behalf of the Commissioner, Reproductive and Child Health. Today's theme is the importance of immunization in protecting children, families, and livelihoods. But the issue is, how can we improve immunization coverage? And I think that's what has brought us here. Isn't it? Why is it that in our respective districts, okay, as a region, as districts and cities, as sub-counties, as parishes and villages, we have not attained 100% immunization coverage. And I want to be very grateful to the chairperson in Tali. Yeah? When he spoke, it's like he's a health worker. Yeah? So Tali is a health worker. But if all of us can take that understanding and tone, that is good. That's good enough. It means that at every burial, at every ceremony, because all of us have a phase where we grow. Imagine that all of us, some of us go to the mosque on Friday. Then some of us on Sunday, we go to church. But there are those who go to church every day. Some of us go to church on Saturday. Isn't it? And many others. So imagine that for every event, every meeting where you have more than 2 people, you speak about immunization coverage. Immunization. Okay? That will just be good enough. And therefore, we will empower the health educators to develop for this region. For us who are still thinking big, we want to develop a community department which is all inclusive, that all districts are represented. That is not a regional referral hospital community health department. I've not seen Goludo is here, I've not seen Dr. Kita, the DHO. So the DHO will be Goludo. We have nominated him as our head of department, public health, for our region, for Resort. But we shall have representation from all districts. ADHO environmental, RDC, COW, health educators, laboratory, surveillance, etc., and civil service organizations. So that we would not think as a region, as a hospital, but as a region. So, and this arrangement of town hall is a unique one. This one would call it a baraza. This one would call it a baraza. And this is just the beginning. And when we go to our respective districts and cities, we can organize such in our respective parishes, sub-counties, to cover the entire district. Because it makes a lot of sense that you have brought a community health worker or a VHT, the traditional healers, the political wing, the technical wing, and other people, okay, to talk about our health. But in this case, we are focusing on immunization. Just because as organized as IT, I just wanted to do some demystification. Some people circulate false propaganda on media. Like when they brought the malaria, when they announced the malaria vaccine, people are saying, they are going to kill you, what, and for many other vaccines, remember. What happens in other countries, especially in those we call developed countries? For example, United Kingdom, what happens in the United States of America, okay? It's what I wanted to flash, so that we see. That for them it is even more strict than we are here in Uganda. So if in the United Kingdom, they can have several vaccines immunized to children and even adults. In the USA, they do the same. Who are we? Who are not yet developed? To refuse what? To refuse vaccination. Because and these people want us to die. Probably some people are given money, that's my thinking, to talk bad about such programs so that at the end of the day, we can perish. Okay? Everybody wants to stay in Africa. Africa is sweet. Okay? So you can see, for example, that is the United Kingdom. Infants receive a series of vaccinations. For them, they start at 8 weeks. Okay? And you can see next 8 weeks, they give them 6 in one vaccine. So those are 6 vaccines: diphtheria, tetanus, pertussis, Haemophilus influenza type B, Hepatitis B. Okay? At 12 weeks, 6 other vaccines. At 16 weeks, 6 other vaccines. And for us here, we are complaining. Okay? Then subsequently, at 1 year, they give them the mumps, measles and rubella vaccine. And here I think for us we have the MR, measles and rubella vaccine. Okay? So you could say, why are they giving us MR? Why are they taking us MR? But even them, they don't take you where they are involved. For them, they don't suffer these diseases of or fecal. Or fecal. Because the toilet coverage is okay, it's 100%. Here, one of the districts whose toilet coverage is below 70%. And that's very dangerous. Okay? In the United States of America, you can see for them they begin at 2 months. Next. And they give several vaccines. Okay? Even PCV and IPV, which we give here. Rota vaccine, which we give here, they also give it. But for us, now they are bringing these ones to finish you. They are bringing our children, they are ending the generation, they are sterilizing us. But our fertility rate is still so high. Actually, even now worrying because children as low as 9 years can conceive. So abantu bari kutubiha, abantu bari kubabiha okugema kuli tuli kutwara obutunanzibwa okumanyisa abantu bona okugema kulungi n'abahera abajungu bakamara byona kana bakora ibibazo nabo bagema mugitegereze. Then in Uganda, we know what to give. Is there anything special? The other in the USA, they are giving diphtheria, tetanus, pertussis, we give. Haemophilus influenza, they give, we give. IPV to dose. Hepatitis B, bagin. PCV, bagin. Rotavirus, bagin. Okay? Same thing. Okay? Then at 9 months, that's when we give vitamin A and measles. MR. Now we are in April, the month of April. In integrated child health days. Plus, but we even said plus. We add plus because there are those women who are supposed to be vaccinated or immunized. There are those people who stay in the water areas who are prone to bilharzia, and they are given Praziquantel. Okay, that's why we have what plus the introduction of new vaccines like now malaria vaccine and also yellow fever vaccine. Okay, and at 10 years, all females who are 10 years. Sometimes we say, okay, maybe we also put 11, maybe put 12, because they have missed. Give hepatitis, human papilloma virus, human papilloma vaccine. Kubasirika cancer yomuwa wanimeni. To prevent against cancer of the cervix. It's a silent killer because you don't feel the pain. When you start leaking, and maybe now other organs. Maybe the joke will be possible. In simple, uruhago, urekari, maybe obune, ati mutano kusasa. It is now too late to help you. Oje kufu. Even if tukuwezeka ukatembea nyoni, ukagenda America, bofu. Sababu you have more than 2 organs affected. Ile kansa ya kuonenda, kansa ya kidobule, kansa ya uhago, kansa ya nzi, and many other organs. Okay? So we should not be right, we should not be deceived. So why are we here? Why are we here? We can share now the objectives. Number 1 is to increase awareness and demand for routine immunization services. And I think the chairperson Yosifai Unyagabu was very audible, okay, and very clear, particularly for underperforming antigens. We have not done well in yellow fever vaccination. We have done it very poorly in Measles-Rubella vaccination, especially Measles-Rubella 2, the second dose of Measles-Rubella. So to go in this region, have you suffered measles? Yes, measles. In 2025. Tukina watu kwa useu. 2025. That means halimabanta watakugemesa. Because in science, ICHD, that is not even only science but also public health. ICHD hard immunity. Abantu abengi obakugemesa abana mwene ohalikulu obakuwa wagemesezi. Bali all was believed Natangirwa is protected. But because we have these epidemics, it means abamubana ikumi mwenda bora tuwagemerwe abategemerwe nao wali bengi muno. So we do not have hard immunity as a result region, and this is very dangerous to the country because even other regions have the same problem. And it's dangerous. Hata ito tino problema kwa amani kwa mfriki heli kurango abazaire twabagambira okugemesa abana bawe abasafu nabo babaho mugiye ebibazi naye roho mugiye. Okay, twena tukoramu abembezi ba government, abembezi ba makanisa, abembezi bo kukama turere mutwena twazawukira ekintu ekyokoraki ekyokugemesa abana abantu. Building public support for the planned April 2025 malaria vaccine introduction in Uganda and intermittent child-based days. So the other false things, the other false propaganda that has been on media, but malaria is finishing us. When the other time I was in the Kamwenge, I think 4 or 5 years ago, during the World Malaria Day in Rwanda, and I said, if we only prevented severe forms of malaria in only one district, we would be able to provide 4 acres of land to about 275 households. What does that all mean? It means that abantu walikuwa batulita. Ukenda kuwaza. No. Hapa uko walingi ni. Hata itakuwa kutunda, you cannot plant coffee. You can't plant coffee. You can't plant avocado. You cannot even plant a little double kill. So do you have a livelihood? Do you talk about operational risk creation? Do you talk about PDM, senior engineer? Do you talk about PDM? Well, there's worker. How? You see? Very dangerous. So now we need to make sure that we eat well, the number 3 is to address any myths and misconceptions surrounding vaccination. And here the office of the RNDC will also work. one. Mwino usowozi, korabo, into clearing. Actually, no, and actually, mwino usowozi wundi, ningira, utakoza kila kuhura bantu nakaharudia, unawazi vitu ya kasare mu. Oh, they can talk, my friend, many things, which have negative effects on the public. So we also need to, but the health officers must take responsibility, okay, to sit with the officer of the RDC, okay, to give them good work, good information, okay, so they can also regulate the others who actually access media, so they not propagate false information, okay. I want to thank you very much and wish you nice deliberations.
Thank you, Doctor, for the meeting objectives. I'm sure they have been very clear. Very clear. We now by some of the next speakers to try to use our local language. We have a cross section of leaders that are here. We have our community health workers. We have the business community. You had the chairpersons of the markets. So kindly let's use, if we could use English and the local language. And where someone cannot manage, I can interpret some of the things. Thank you. We are still waiting for the minister, but as we are, I'm told the minister is in the building. I think shortly he will be joining us with Dr. Webster. But without wasting time, we want to invite Dr. Jen Navakosa from the Ministry of Health. Let's join hands and welcome Dr. Jen. We have a presentation on malaria. She's going to have a presentation on malaria. Whoever has joined us during the communication from Dr. Wahizi, you are welcome and feel at home.
Morning. Good afternoon. Good afternoon. The Executive Director, the District Health Officers, all protocol observed. I want to really take a short time to speak to the malaria vaccine introduction. Okay. Mine this afternoon is to speak to the malaria vaccine introduction. I'll give a brief update on the performance of both programs that are collaborating to ensure that this malaria vaccine rollout fits well into the routine immunization, but also into other malaria interventions, because our goal together is to reduce the all-cause and the 5 mortality. What's the situation of malaria at a glance? When I say this in bullet number 1, the global burden, it is not to celebrate, but to remind us that we still need to pull our sleeves up, hold the grip tighter, and make sure we shift from that position. As I speak, we are the 3rd global contributor to the malaria burden. The report being shared here is the report of 2024, reporting on the situation of 2023, where Uganda still was the 3rd global contributor. I think we've been 3rd for the entire decade. and we contributed at that time 4.8 to the global malaria cases, 4.8%, dropping from 5.1 but maintaining the third place. So the good news there was that we managed to reduce cases as Uganda. I remember in 2022 when DRC reduced, Uganda was not very impressed because we had increased then, but we still contributed about 12 million cases in 2023. And we are 10th contributor to the number of deaths. And there we contributed about 2.8 to the global malaria deaths. That year we had about 560 something deaths, but 440,000 were children under 5 of those total deaths. And I want to note here that in that World Malaria Report of 2023, many countries were already vaccinated. But in that report, there's nothing like a child died of an AFI, one of them being malaria AFI. That is a adverse event following immunization. When a child is immunized, then they get a bad reaction. We normally follow that up and investigate and try to understand why it's happening. While we lost 440,000 due to malaria, we didn't pick anyone dying because they got a side effect of malaria. So we need to be comparing, not saying. Do we want to keep malaria with us and keep our children away from being vaccinated? That's an answer we shall have later. Our country here does an annual health sector performance review. The snapshot I'm giving in the next band is the annual health sector performance report of 2022-2023. Of the patients that come and go back home, outpatient department attendance, 33 out of 100 that come are because of malaria. Then the other 67 is contributed to by the other diseases. Of the patients that get admitted, 22 out of 100 are there because of malaria. Of the deaths that happen, those patients that are admitted and they die, 11 out of 100 die because of malaria. And now when it comes to children, of the patients that come to the OPD, outpatient department, because they have malaria, 20 out of 100 are children. And please note here, we have less because most of them come in as severe what? Malaria. Number 2, we have 44%, 44 out of 100 of the patients that get admitted are children under 5. And then 53.7 of the malaria deaths are children under 5. And then 35.7, let's just say 36 out of 100 of the total children that die under 5. The 36 out of 100, when you have 100 children under 5 die, 36 are dying because of malaria. So we need to be thinking through. Because I know questions like, why did they give everyone? How about adults? In a situation where I don't have enough, and something is there, where wouldn't you want to start with, especially those that are most affected? This is what we are doing. And then, malaria doesn't stop there. I like the submission of the executive director in terms of, because you need to be speaking to the things people understand. How many acres of land would you eventually acquire if you reduce the burden of malaria? I never thought about that, and I hope our SBCC teams have picked this, because it can be a good message. Let's find something that sells. Because just look here. Remember, this situation is when our medicines, you all know that our medicines of malaria are not provided at a cost. number one. Number two, even government is supported by donors to get this medicine. So let's take note of that. But amidst that, government of Uganda spends $333 US dollars on malaria interventions. And each episode of malaria costs the family about $3, or you can say that a family spends about 30,000 per episode. Let's look at an average home with 5 people in the house. And then you have someone getting about 2 to 3 episodes per year. If you spend 30 per episode, how much do you spend progressively in your house per year? And cumulatively, what would it have bought? So we need to be thinking through. And then while Uganda has done well, those bars you're seeing, we're looking at the death in the children under 5 and how they've been reducing over the years. You can see the red bar on top is speaking to the under 5. We've been reducing, but we are not yet there. No child should be dying under 5. Next slide. But important to note here that countries like Ghana, remember when we introduced, as we introduced the malaria vaccine, Uganda became the 19th country. Other countries started in 2019. The countries like Ghana, Malawi, and Kenya, and eventually, I'm sincerely sorry. Because I was not so good at tutorial as actually wondering how to simplify. I'm really sorry. So if you can just take me a bit back. Kati wano tubadde tutunuulira embeera y'amaleeri etya. Ekifo ekyokusatu kirabika ng'ekirungi. Tebagamba nti oli wakusatu. Naye oli wakusatu mu ki? Mu balwadde b'omusujja mu nsi yonna, ffe tuwaayo ebitundu 5 buli 100. Omwaka gwa 2023 twalina cases miliyoni 12 ng'eggwanga. Bwe butuuka ku bantu abafa, era nabo tuli 10. Tuseevuddeko mu bafa ne tuva ku 7 ne tugenda mu 10. Naye twandibadde tetubeera namu ebyo ebifo. Banga singa mulaba ensi eziri mu bifo ebibiri ebyokusatu, njagala tulowoozeeko Nigeria. Nigeria mulimu Uganda nga 6 oba 8. Ate mulimu n'ebitundu ewali okulwana okw'amaanyi tosobola na kutuukayo. Democratic Republic of Congo yeddako awo kati ffenno ne tubeera bakusatu. Naye Democratic Republic of Congo mumanyi obunene bwayo. Mumanyi n'obufuzi bwayo obwetengeredde obukomo. Naye ffe obufuzi bwaffe bwe buli. Tulina structures buli kimu weekiri, naye tuli bakumeka? Bakusatu. Kiki ekitagenda bulungi? Tulina okwebuuza ebibuuzo ebyo. Kiki ekitagenda bulungi? Siriya ensi ebbiri, abantu bangi, kyekisooka. Ekyokubiri, balina entalo. N'obukulembeze tebwetengeredde bulungi. Kaakati, ffe wano obukulembeze bwaffe bwetengeredde. Buli kitundu paka ku kyalo wali abakulembeze. Naye abakulembeze baffe twebuuze. Tutwala malaria ng'ekintu ekikulu kye tulina okuteekako attention. Tugende nga tutyebuuza ffenna abali wano omukulembeze waffe ow'enjawulo. Tuyinza okubagayirawo nga kyekyo ekintu ekikyagaanye. Singa tukitwala bwe tutyo nga buli kimu kijja kukola ki? Kijja kukyuka. So kati wali batulaga, tulabye bulungi nti omusujja kababa abaana abajja bukyali, kababa abaana abajja mu kulaba omusawo ne baddayo ewaka oba abantu kwe kusinga. Paka bw'oba n'abantu 10 mu layini nga 3 ku bo balina omusujja gwesinga balala balina bulwadde. Bw'oba owadde abantu ebitanda 2 ku 10 nga bamusujja. Ng'ofiirwa abantu 16 naye ng'ate 10 baana baki? Baana bato. ng'abaana abafanga bali wansi w'emyaka 5, abaana 36 ku buli 100 bafa musujja gwaki? Gwa nsiri. Wano mu nkolagana yaffe
the minister is arriving. We want to request the LC file, the RDC, the director, welcome the minister outside. The presentation will resume after we have received the minister and after the answers. Kindly we join hands and welcome the minister. The people have mentioned the LC file, the vice chairperson, Toroko, I saw her here. The religious leaders joined and received the minister. Haji Bashir and the pastor later joined and received the minister. As she gets in, kindly let's welcome her.
Icumu twemererwa kutahamu kugambira abantu bonna.
They have come at the right time when they are the next.
Let's rise and welcome the minister. Accompanied by different leaders of the region. And we shall remain standing for anthems. We want to begin with the anthems. National anthem, East African anthem, we end with the Kingdom anthem. Standards to take us through.
Okay, let's begin with the Ugandan anthem. Oh, Uganda,
Uganda, hold thee, we lay our future in thy hands. United, free for liberty, together we'll always stand.
Mungu taomba tuilinde,
tuiye Afrika Mashariki, tuwezeshe kuishi na amani, tueneze na malengo yetu. Jumuiya yetu sote tuilinde, tuwajibike, tuimarike. Umoja wetu ni nguzo yetu, idumu jumuiya yetu.
Total Kingdom anthem.
Mukama wetu abutambe ntale ya toro, karamalo mukumafuzi, angirizo mweriwa. Omukama wetu murungi, omukame ntale ya toro, karamalo mukumafuzi, angirizo mweriwa.
We can take our seats. We had prayed. Honorable Minister of State for Permanent Care, I've already Margaret Mugisa, we welcome you to this town hall meeting. It is more of a baraza, a community meeting. It is more of an engagement, an interaction. And the theme of this meeting is very clear. The importance of immunization in protecting children, families, and livelihoods is very clear. Honorable Minister, our program is very clear. Some presentations had already been made. And when you get in, you found Dr. Jane from the Ministry of Health who was presenting the data concerning malaria and vaccination in this country. The director of Puerto Rican Referral Hospital, senior consultant, Dr. Liza had spoken. Political leaders, the chairperson, S.K. Vinyagaro, had given the marks on behalf of political leaders. The other DC, Torogo, had spoken. Now, when you're getting in, you found a presentation from Dr. Namakosa Jen. I request you allow her to proceed with the presentation. Then we shall invite Dr. Henry Melessa to speak. Then he will invite the minister to give a keynote speech. Then after we shall have a panel discussion. Those that are supposed to take part in the panel are aware and ready to take part in the panel. So far, that is our program. I request Jane Namakosa to take us through her presentation. Thank you.
Honorable Minister, Executive Director, the DHOs, all protocol observed. Allow me to continue. I had spoken to this slide, and at the time the Honorable Minister came in, I was trying to summarize in the local language that can be understood by all of us. So, mbadde ngamba nti bwe tutunuulira ripooti yaffe ey'ekitongole ky'ebyobulamu eya 2023, 2024 kiraga nti buli lw'olaba ng'abantu 10 nga basimbye layini nga ne bagenda kuddayo awaka, abalwadde abajja ne balabwa ne baddayo, abalwadde bwe baba 10 nga bali ku benchi balinze, abalwadde 3 ku 4 baba balina musujja gwa nsi. Buli lw'olaba abali ku bitanda nga bali balwadde, abalwadde 2 ku 3 baba balina musujja gwa nsi. Ate buli lunaku abantu 16 bafa, naye nga 10 ku bo baana. Bw'otunuulira ebibalo byaffe, bw'otunuulira abaana, abantu abaweebwa ebitanda, abaana 44, abaana abali wansi wa myaka 5 babeera baana nga baweza ebitundu 44 ku bantu 100. Naye bw'otunuulira abaana abafa abali wansi w'emyaka 5 abafa obulwadde bwonna, 36 ku buli 100 kwabo 36 baba bafite musujja gwa nsiri. Ate gavumenti yaffe waayo obuwanana bungi, naye ate wano ojjukiranga omuntu bw'agenda eddagala liba limuyambiddwako nga talisasula. Naye tutunuulire famire emu, ebiseera ebisinga amayumba gaffe mu Uganda gabeeramu abantu 5 ku 6. Buli mwaka omuntu omu afuna omusujja emirundi ng'ebiri oba 3. Naye buli mulundi omuntu gw'afuna omusujja, famire nga teebuze eddagala wabula okutambula n'entuka mu ddwaliro okulaagulayo obuntu obutono, efulumya emitwalo 3 ng'eddagala jjukira liweereddwa bwereere. Kakati tuli abantu 5 ku 6 buli muntu afuna emirundi 2 wakati w'emirundi 23. Olwo famire buli mwaka efulumya ensimbi zenkana watusobola okubalamu awo. Era ng'eggwanga tubadde tetutambudde bubi mu kukendeeza omuwendo gw'abaana abafa nga bali wansi w'emyaka 5. Naye ate kye tweyama ne bannaffe abalala tetunnakituukako. Ekitegeeza nti tukyalina ekyokola. Bwe tutunamu awo abantu bwe baba nga bakyafa nnyo omusujja gw'ensiri, naddala abaana abato. Kiyinza okuba nga y'ensonga lwaki tetutuuse gye tulaga. N'ekirala bw'otunuulira ensi ezaakola vaccine edda okutandika 2019, kuba Uganda tuli ba 19 kati. Waliwo ensi nga Ghana, Malawi, Kenya zaatandika dda 2019. Ebibalo ebivaayo biraga nti baakendeeza okufa kw'abantu, ku bantu 100 abafa baakendeeza ddala abantu nga 13. So nga bamaze okukozesa vaccine eno. Ate nga jjukira okumalirayo ddala babadde bakyatawaana. Kyemanyi kati kye bakozeeko kiyinza n'okuba nga omuwendo gwo gukyuse nnyo. So osanga ekituufu kiri nti bwe tunaakozesa vaccine eno tujja kukendeeza abantu abafa. Ne guno omuwendo gwe twagala okukendeeza tugukendeereze ddala. That's how that slide is summarized. Next slide. When we were planning in 2022, after guidance from WHO, the country was told to prioritize those districts that have moderate, high, and very high transmission. Kati, that map you're seeing in orange, it has 2022 incidents. Is what we used to plan our vaccine rollout. And in that regard, where you're seeing dark orange, the next orange, and the lighter orange. The lighter orange is moderate transmission. The next orange is high transmission, and then the dark orange was then very high transmission. Then the light brown and white is very low transmission. So according to the World Health Organization, the light brown and white is not priority for the vaccine rollouts because they are low and very low transmission. Just to break it down for us to understand it easily, because all of us here need to understand what we mean by very high and what we mean by high and what we mean by very low. Let's just go back to that one because we don't need to understand it. For the very high, these are people who are sick and they are coming to the facility, but they are coming from the community. It means that in that community, for the very high, every time you meet 1,000 people, 750 will be carrying malaria parasites. And that means every time the mosquito bites, it has very high chances. And the next brown there means that every time you meet 1,000 people, about 450 will be carrying malaria parasites. And then the moderate means that every time you meet 1,000 people, 250 will be carrying malaria parasites. So this is how we classify. And so because there we have very high chances, that is where we started. Of course, the picture kept changing into 2023, but we know that our picture is not stable, so we kept changing it. If I can summarize it for some of us who want to understand it better, where we are introducing abantu bwe baba 100 nga bali mu kitundu ekyo osanga nga 750 balina obuwuka obuleeta omusujja gwaki eyo gye gusinga okuba omungi. Awaddako okuba omungi buli lw'osanga abantu 450 baba balina obuwuka. Awaddako okuba omungi lw'osanga abantu 225 baba balina obuwuka. Nekitegeeza nti ensiri bw'eba enoonya ekyokulya eri gye gusinga obungi buli lw'erume ebeera n'emikisa mingi nnyo. Era ky'oba olaba eyo gye twatandikidde. Era kati abakulembeze abali wano omulimu eyo gye mulaba naye wano we tuli okuggyako ebituba ebimu bye tujja okulaba tetulina nnyo tetulinga bali eri waggulu gyekikutte ennyo. So naye ate naffe tulina okukola ennyo okulaba nga tufuuka white because kisoboka. Next slide. Which are the regions that are contributing to malaria deaths? Toro, where we are, is one of the regions. At that time, we contributed 12% to the deaths, followed by West Nile, and followed by Usoga, followed by Bunyoro, followed by North Central, and followed by Acholi. Toro here, mainly the regional referral hospital, is where most of these cases come from. But notably, these cases are not coming from Fort Portal town, or they are coming from districts like Kamwenge, they are coming from districts like Chedegwa, they are coming from districts like Ntoroko. And some of these districts actually, most of them have many refugees. And so that's why you see a similar picture in Bunyoro. Bunyoro, most of them are coming from districts like Chikube, Buisa, and then of course Kakumiro. Kakumiro also has people that are traveling from areas like Chigezi, and then they come and settle there. Remember, when you're coming from Chigezi, you've not suffered malaria, and now you come into an area where there's some malaria. When you get infected, you definitely will come in as severe malaria. But because you're not a person of the place, you may be there to seek care. By the time you come, you're into severe malaria and you're dying. North Central, still we have some non-immune groups coming from some places like Bukoma and Simbi. North Central, we have some people coming into the regional referral hospital like Molabo, and we have another problem of people coming from private sector where they delay because the private sector person wants to first get money, and yet they are not adhering to the guidelines provided by Ministry of Health. So North Central, and by the time they send them to the big hospitals, they are really, really sick. Actually, you saw the map, they are still very dark, and so is Lamu. South Central, we have areas like Bukoma and Simbi giving us trouble. Bugisu, their cases are coming from Bukedi. Teso, the cases are high. Karamoja used to be one of the highest until we introduced the seasonal malaria chemo prevention. So now it's one of the lowest. So Bukedi posts most of their cases to Bugisu. I am explaining this because I know questions are going to come through when we see that how come Tororo has very high cases and yet we are only giving a few districts the vaccine? Those districts that are receiving the vaccine is where the cases are coming from. Next slide. So you're seeing the districts that are really registering high cases, and for each of them we understand the reason. You'll see that most of them that have regional referral hospitals actually have a lot of cases. Because most of our communities delay to seek care. There's very low risk perception for malaria. Recently, we lost a student in one of the prominent schools. But when you listen to that story, you'll understand our community perception for malaria. This girl complained in the morning that I'm not feeling well. The father took her to a clinic. They did a slide. She was positive. They gave her treatment, and they took her to school. Because malaria, as all of us think, it's a simple disease. She reaches school, she goes to the dormitory, every dose she was trying, she was not tolerating it, it was coming back, until she felt bad, she went to the school nurse. By the time the school nurse saw, she was already into severe malaria, and she never survived. So it's a true perception of how most of us think malaria is. It's simple disease, but it is not as simple. All these cases we are seeing here, why our regional referral hospitals are congested is because if people were seeking care, the moment they felt bad or unwell, we wouldn't be losing patients. But most of the people going, that's why you're seeing Hoima, Mbale, you may drop off the list, it used to be part of this list. Maybe it's like a regional referral where it is you're seeing Kabarole, Kampala. Everywhere you have a regional referral, the cases are high because our patients delay to seek care. Next slide. So, not that Uganda as a country is not doing much. We have a Uganda malaria elimination and strategic plan of 2021-2025. It's about to end. In there, we designed measures or interventions to fight malaria. We didn't just design, we also did appropriate allocation of these interventions. Because we know that some interventions can't work in some areas. So the different color codes show the different intervention packages. Measures were put together in packages and allocated certain areas. And these are the color codes you see. When you're seeing CM, it means case management. That is test and treat. It's done at the health facility, it is done at the community for the children under 5, and that one is done in the entire Uganda. Then where you're seeing IPTP, that is intermittent preventive treatment of malaria in pregnancy. This is prevention treatment given to the pregnant woman to prevent them from getting malaria. This one is done for the entire Uganda. Then mosquito nets, where you're seeing LLIN, this is mosquito nets. We avoid calling them mosquito bed nets because once you put the word bed, then some people don't use. So we call them mosquito nets. These ones are given to all Ugandans everywhere. So every 3 years we come and do the campaign. Next year we are starting another campaign. But the campaign will help us achieve good coverage. But of course we know that some nets get lost, some nets disappear. And yet what gives us mileage is a coverage of over 85%. So we continue to give mosquito nets through antenatal and the immunization clinics. This one is done countrywide. But now we have special interventions for specific parts of Uganda. Where you're seeing blue, on top of the 3 that I've mentioned, is the light blue, we have indoor residual spraying. We spray the walls of the house so that when the mosquito comes in to feed, as it rests on the wall, it picks the chemical weakens it, and then it's not able to feed and it eventually dies. This is indoor residual spraying. It was based on the behavior of the mosquito that transmits malaria. It fits inside the house and rests inside the house. That is why we approached it that way. So we picked the areas where malaria was too much. Those are the light blue areas, the West Nile, Teso region, a bit of Lamu, and Busoga. Now where you're seeing dark blue, we are doing the test and treat, the prevention of malaria in pregnancies and mosquito nets, and we are also treating the children under 5 at the community, where you're seeing light blue. Where you're seeing pink, we are doing the other interventions that we do everywhere, the ones I mentioned. But there we do something unique. The children under 5 are given medicine to prevent them from getting malaria during the time when malaria transmission is so high. That is the Karamoja region, the pink. And that is called seasonal malaria chemo prevention. I know you'll ask me that why isn't it done in Renzori? Renzori, the transmission is 2 times There it's once in one prolonged period, May to September, so you can know and give the medicine. But also, when you look at Karamoja, and Karamoja had the highest transmission. Every time you met people, 100 people in Karamoja in 2019, every time you met 100, 34 of them would be carrying malaria parasites. While if I can give an example of Toro, then every time you met 100 people in some parts of Toro, like Fort Portal, less than 5 had malaria parasites. So you'll understand why we gave Karamoja special attention. And then those of you who have never been to Karamoja, you can't spray there. The beautiful houses cannot accommodate spraying. And then those people's way of life, they prefer keeping out to look after their animals. And at times they move with their children. So we needed to think through something that works for them. Then where you're seeing light yellow, we are doing larviciding. The baby mosquito survives in water. So we put chemical in the water so that it doesn't grow. Where you're seeing dark yellow, we only do the other interventions with larviciding, but where it's light, we are also doing management at the community level. So we are trying to say here that the vaccine is not going to come and replace this intervention, but it's going to come and fit in there. It's going to be part of the package. So here, we're trying to say that the vaccine is not a magic bullet. That once a child receives the vaccine, then they will be very safe. Here, we're trying to emphasize that for you to reduce the burden of malaria, you must combine measures. They work better together. In that bar that is totally dark blue, there you're not doing anything. Isn't this what most of us do? We don't use the mosquito net, we don't close windows. When we are sick, we don't seek care. And that's why we have malaria always in our community. And then when you use the mosquito net, you reduce by 45%. And this is if you use correctly. This is if you use every day. You care for the net like you care for your dress. You wash it when it's started, not with Omo and Jig, but with Baso. You don't hang it under scorching sunshine, but you put it under the shade. You look after it and use it every day, so that it's effective. This is when you get the 45%. But the Uganda, what we picked from the literature of Uganda, actually, we achieve about 20% because of our ways of treating the nets. How about when you use the mosquito net and the seasonal malaria chemoprevention with swab? There you reduce by 78%. And when you do the net, the seasonal malaria chemoprevention and vaccine, you reduce the burden by 92%. So here the take-home message is that let's use all combinations together. Currently, we have 14 antigens when you add the malaria vaccine. We have the BCG, that is for tuberculosis. We have the DPT, that is for diphtheria, pertussis, and tetanus, and then we have the Measles-Rubella, we have the yellow fever, we have polio, we have the diarrhea, rotavirus, we have tetanus, and we have that for cancer of the cervix. Here they are trying to show us how UNEP has been performing. What I want us to pick here, the reds, the poorly performing vaccines, the ones that are not being sold for, are the ones in red. Maybe during our discussion, we need to ask ourselves key questions. One of them is the Measles-Rubella, especially the second dose. The other is yellow fever. We also have Hepatitis B 0 dose. And Rota has greatly improved. But also the Tetanus-Diphtheria, the one our women receive. What is happening around these vaccines? Where is the problem? I think we need to further discuss that. Next slide. Here we are trying to select to show how the different vaccines, but you can still see that throughout the years, Measles-Rubella 2, the one we get at 1.5 years, is not yet picking it. And yet we are getting outbreaks in different corners. Can we pull up our socks? Can we do better? Next slide. Here they are trying to show us how we are performing, but I think we've greatly improved. You can see most of it is green, save for a few yellows, which I think can also improve. Can the leaders from those districts see themselves where we have any yellows in the red zone region? Is that Chenjojo that I'm seeing? As if I'm seeing Chenjojo somewhere. We need to work a little bit harder. What are some of these things we can work on? Next slide. And here they are trying to show us, are we happy with our region? Are we okay?
Number 8.
Do we want to achieve 100%? What can we do different? So let's see the next slide. So having looked at that, we have the malaria situation, we have the performance scene. So clearly we all appreciate that we need the malaria vaccine. Vaccine ya malaria tujetanga. Naye ate tulabye ne bwe tukola. Tukoze tutya okulaba nga tukola bulungi mu byokugema ebirala. Vaccine naye esobola okutuuka ku baana. I think that discussion will be very important. So here we are trying to show that as we introduce the vaccine, it's not going to be a campaign. It's going to fit into the routine immunization that is led by the Uganda expanded program of immunization. That program is a very well organized program. It operates on 5 structures. And these structures are guided by the building blocks of the health systems. The pillar number 1 is on program management. We have service delivery, we have logistics and supply chain, then we have advocacy, social behavior change communication, then we have surveillance, monitoring and evaluation. Just to make it simple for some of our friends, kindly let's go back a bit. Program management, buno bwe bukulembeze obulaba nti ebintu bitambula bulungi n'ebyetaago gy'ebiri. Service delivery, abatuusa services ku bantu ababizeetaaga, abasawo baffe, okumanya kwabwe, okubeerawo kwabwe nti bwe bali n'okumanya kwabwe. Eddagala lyennyini n'ebigenderako, kati vaccine yeetaaga ebintu ebikikuuma ng'ekola. Oyinza okukola ebyo byonna n'oba n'obukulembeze obulungi, abasawo gye bali, naye singa abantu tebakkiriziganya naawe kino ne bamanya nti kibayamba, era tojja kubaako kyokola. Ewasemba wali olina okulaba by'okola nti bikola era n'abantu babifuna era bikola bulungi. Bw'oba tolina miwendo oba weerimba weka, obeeranga you like an ostrich, so eripya kyekola. So when we are developing the malaria vaccine introduction plan, we aligned the specific objectives onto those pillars. If I can quickly, I'll come from bottom and end with up. If I can quickly speak to objective number 1, this one, through the program management, make sure resources are available, guidelines are there, and people are working together the same way at all the levels. That's why we're speaking to you today. So we want to make sure that by 2026, every district where we're rolling out has the guidelines and they're working in the expected way and they have the resources. Number 2, we want to make sure that the mothers, the fathers, the people in the community are aware that the vaccine is there, they are demanding for it, and they are using it. At least if we can have 90% of all those do that, then I think that would be a good achievement. Then, still by 2026, we want to make sure that all the 107 districts have a vaccine that works. That means it's not enough for you to have the vaccines there, but they should also be good quality. That means your fridges should be working, your ice packs should be working, your cool boxes you should have adequate number of cool boxes, and all those ones. And then, of course, after you have done everything, you should also manage your waste very well. Then, by 2026, we want to be sure that all our eligible children, and I want to say this slowly, eligible children who must receive. This vaccine is for only children. This vaccine is for only what? It's unfortunate that it is me saying it, because then when people get to know that I'm a pediatrician, they may think I had a hand in this. I didn't have, but this is a recommendation. This vaccine is for children. This vaccine is, we shall start with those that are 6 months to 11 months, and then I'll unpack the rest later. So then also you remember that the causes of malaria, we have about 4 types of parasites. So this vaccine is only for that vaccine parasite that causes most of the malaria here, that is falciparum. Okay? So those are things we should remember. So we want those children that we are targeting to be able to, at least 80% of them to receive all the 4 doses. And then we want to make sure that all districts that are implementing this vaccine are able to count the numbers, report them, and eventually we are able to tell if this vaccine is working. But then also we need to be answering some of these questions of the people who don't believe in us, that are reporting that the vaccine is not safe. We need to be convincing them that look here, we've not registered any safety issues. So we are also going to be picking some of those cases and making sure they are happening because of the vaccine or not happening because of the vaccine. Next slide. So you can see, if you looked at objective, at the end of the day, in 2026, we want, currently you saw that 36 out of 100 children die because of malaria. So we want to try and reduce that to 7% by 2026. Then we also reduce the admissions from 44 to 10%. But to achieve that, we must make sure that 100% of the districts that are implementing have guidelines and they have resources. And then in that purple one, we want to make sure that everyone concerned is sensitized and they are doing the right practices, at least 90%. And then we want to make sure that 95% of our districts have functional equipment, they have the vaccines, and that they are able to provide quality vaccine. And then we want to be very sure that our providers in all the 107 districts know what to do and they are available to provide. And then we want to be very sure that our dropout rate is below 10% at any given time. We also want to make sure that all our districts that are implementing are reporting. Next slide. This is just emphasizing some of the things we are doing under objective number 2, because it is the main objective for this kind of meeting, making sure that we own the malaria vaccine rollout, but also the vaccination of children against other diseases and the prevention of malaria. Our rollout, based on the map we saw earlier, we are going everywhere where it's purple. Clearly, you can see that in West Nile, we are covering all the 13 districts. Achon, we are covering all the 9 districts. Lamu, we are covering all the 10 districts. Karamoja, we are covering all the 9 districts. Teso, we are covering all the 10 districts. Bugisu, we are covering only 5, and Bukedi, we are covering all the 7 districts, but none in Sebei. We have a Sebei sub-region that has Kapchora, it has Kapchora, there are 3 districts in there, but those ones, none of them is being covered because they are all very low transmission. North Uganda, we are not covering Kampala, we are not covering Wakiso, we are not covering Impiji. And then South Uganda, we are not covering Kalangala. Bunyoro, we are going to Chigandongo, Chikube, and Bulisa. And then Resort region, we are going to Chedekwa, Chitagwenda, Kasese, Kamwege, and Bundibujo. And Kole, we are going to Ibanda, we are going to Isindiro, Kazo, Chirukura, Rubirizi, and Chikes, we are only doing Kanungu. We are starting there, but eventually we shall go everywhere. This is going to be progressive. We have started with children, but eventually we shall go to everyone because every Ugandan is at risk. But we started with the most vulnerable districts and the most vulnerable age group. Please note that. Eventually, we shall reach everyone. The children we are starting with are 1 million and with 3 million doses of the vaccine. I know when someone does quick mathematics, they will wonder if the Ministry of Health knows mathematics. Because quickly, if you have 1.1, you'd expect like 4.4. But why 3 million? Remember, our target coverage is 85%. And when you factor in wasted and buffer, that's how you come in with the 3 million. Okay, next slide. So, like I said, who is eligible? We started on, this is day 15 of the rollout. We launched on the 2nd of April. Since then, we've been up and running. And we are working with routine immunization. This vaccine is going to be provided through the routine immunization. It is going to be provided at the health facilities, at the static clinics, and then also at the community outreaches for the hard to reach at the known outreach posts. So who is eligible? Any child that is 6 to 11 months is eligible to start. And once they start, for as long as they are still below 5 years, they must be supported to complete the 4 doses. You're not a beneficiary of this vaccine until you have completed the 4 doses. So the first dose will be given at 6 months, and the next dose will be given at 7 months, and the 3rd dose will be given at 8 months. And then the booster dose will be given at 1.5 years. Please note that that happens at a less busy time when a child has stopped coming, so there's some work to do. So in order to achieve that, there are some key activities we've been doing, like orienting teams like you, because we know you're very important. Messages on radios, these are ongoing. Checking if our different stakeholders are ready. This was completed. Vaccines arrived on the 7th of March and they were distributed to the districts and eventually facilities. We can hear from our friends like from Bundibujo here. They can let us know if any of their facilities are missing the vaccine because the information we have at the center is that every facility has received. As of now, we already did trainings both at the national level, district level, sub-county level, including orientation of our dear VHTs. We continue to do radio talk shows. We already assessments the final time. We continue to update our top management, the immunization coordination committee, the technical coordination committee on a quarterly basis. The launch and introduction happened on the 2nd of April in Apache district. We picked Apache because it has the highest prevalence in the world. We We were supposed to immediately deploy supervisors, but because we had competing priorities, we've been doing yellow fever. That was postponed, probably we're going to do it after Easter. And then we shall do a post-immunization evaluation to see how we were working, and then support supervision. We've done a lot around communicating. Those are things we are doing. Next slide. UNEP did not start yesterday. We've been working. All we ask for is to get stronger. This vaccine has to work with a strong immunization. We are assessing what we are doing. We are trying to see if people have the messages. Next slide. These are the number of things we have done. We've oriented the Pediatric Association, the different professional bodies. We've engaged parliamentarians. We engage in media. Some of you must have seen the messages. We've engaged religious leaders, cultural leaders. And this that we're doing here, we've done elsewhere. Here they're showing us how we've engaged the different stakeholders. Next slide. That's all engagement. This is now top management. These materials are available for the different stakeholders. They are there in that number, and we continue to produce more. You can pick some. Next slide. Next slide, please. These are the different materials. They are showing them there. These are the different things we have done. Go on. Kindly go on. So these materials, these messages are there. Key messages. Is vaccination important? Yes, it is. It's going to reduce admissions. Who is eligible? Children 6 to 11. What should I do when a child misses? Please report. The vaccine is an injection. It's not a tablet. It's not a drop. It's given on the right hand here. How many doses? 4. I already told you. 6 months, 7 months, 8 months, and then the 4th dose at 18 months. When the child does not complete, then they will not benefit. When you don't complete the 4 doses, you will not realize the benefit. So they must complete. Because even when you get immunized in a natural way, you need a number of exposures before you can acquire immunity. So this is why you also need more. But studies are going on. At some point, we shall get a single dose. Okay? At some point, but for now, we are working with 4 doses. How does the malaria? Is it safe? This vaccine is safe, very safe. The known side effects is pain, some bit of swelling, because it's an injection. Okay? But these are self-limiting. Irritability, because the baby feels pain, they'll be irritable. That's where the irritability. And then fever, because of the way the vaccine works. As it generates that immunity, there's some inflammation and changes in temperature. So that is why the child gets a fever. And very rarely, febrile convulsions. And these are self-limiting. We all know febrile convulsions. For us back home, we call it a yawe. When a child gets a fever, usually they do convulse if it's not well managed. And these are self-limiting. Some anti-vaxxers are saying epilepsy. Please note there is no documented epilepsy. They are saying children, mothers died because they were vaccinated. There's nothing like that. They are saying cerebral malaria. There is no literature pointing to cerebral malaria because of vaccination. Okay? And that is why when I started, I told you in the 2024 report, 440,000 children under 5 died of malaria, but none of them died because they received malaria vaccine for where it's already being given. So that's very important. How to use it? Usually these side effects are self-limiting. After 24 hours, they are gone. But if they go beyond 48, go to the health worker. Will the private sector give out? Yes, they will give out. But this vaccine is free. Okay? It is free. Who should not receive? Adults and children above 5. Why? We are rationalizing. Okay? We are using the little we have. We don't have enough vaccines, but also the vaccines have been well studied in children, and children are more vulnerable, so we are starting with them. For now, the adults, because of your repeated exposures, you already have natural immunity. Let's maintain other interventions. You have to first test. If a child has no symptoms, you don't need to first test them. But if a child has symptoms, please first assess and test them. If they have malaria, first treat the malaria. When they recover, vaccinate. Because when you vaccinate them when they have malaria, this malaria might progress and cause complications, and then they think it is a side effect of the vaccine. Lastly, does malaria vaccine replace other interventions? No, I already said this. I'm not going to repeat. Why is the vaccine not administered to adults? That one you can't even answer because I've said this. We highly recognize you as key stakeholders. We know you interact with a lot of people. Without you, we can't reach these people. Kindly, for where we can't reach, be there to communicate that vaccines work. Even the new one, malaria vaccine, works. So people should come and partake of it. Mobilize. This information is being given to you so that you understand better and help us clear the myths and misconceptions. We commit to work with you. We've already developed materials for your reference. Welcome on board. And we pray for a very successful collaboration. Thank you so much.
Thank you, Doctor. As the head part, I think Catherine, you are the leader in this. I request everyone to rise and see some colleagues closing. Yes, can we do a later stand? Yeah, can see colleagues closing. As Atei is mobilizing, thank Doctor for this lengthy presentation. Atei, you pick those flowers. Yes. Then you pour them somewhere and pick from other corners. Yes.
From in front, from behind, from down. Let's put in the basket. Doctor, are you receiving?
Doctor, receive. All those flowers are yours.
Let's pour her. And then clap.
We can take back our seats. Thank you, Ateni. Thank you, Doctor. She has been elaborate enough. She has managed to translate what she could in Uganda. I'm sure we're all at par. And now that we're expecting to have the Dr. Henry Mwelesa, the chairperson of the Health Science Commission. I think he might not be with us or he's joining us. But without wasting time, we want to invite the executive consultant, senior executive consultant for the General Referral Hospital to invite the minister. Doctor, you're welcome. You'll fit in those shoes. Doctor is saying the chairperson is fine. I want to invite the vice chairperson, Elsie Halutoroko, to come and welcome the minister. She's going to give her keynote speech. Thank you. Let's clap to the chairperson. That's the chairperson. When the chairperson is not here, she is. Yes. Madam Chairperson, you're welcome.
Ladies in the house.
Then after the keynote speech from the minister, we shall have a panel discussion. I kindly request to reserve the questions. We shall do it at once after the panel discussion. Thank you.
Thank you, moderator. Ladies in the house, good afternoon. Yes, dear. Our Honorable Minister, Award, Obarekuita Mama, protocol observed. My name is Kabo Ed.
I'm the district vice chairperson of Toro. I'm very delighted to be in front of you. And I'm happy for this engagement. I thank the partners plus the ministry for organizing this fantastic town hall meeting. As a dialogue, we are going to discuss more. They have given me the honor to invite the State Minister for Primary Health Care, our only Honorable Margaret. You are most welcome, Mama. This is your time to come and give us your key notes. The audience is yours. Thank you so much.
Too much sanitizer, so I think it's sliding out.
Give us
Sliding out of my hands. I hope it's afternoon. Good afternoon, everybody. Kindly allow me to write on the protocol that has already been established by all the previous speakers in the interest of time. I really want to welcome you to this meeting. It's very, very important for our health, for our well-being, and for our future. We can only have a future which is with a healthy population. If the population is not healthy, I don't think we have a good future. I want to thank the team from the Ministry of Health, the Executive Director of the Regional Faro Hospital here, who have really put in a lot of effort to organize this meeting in partnership with our usual partners, as you can see up here. I want to thank you, doctors, who came and gave a very good explanation. I just wanted to tell you, doctor, that here people don't understand Uganda. You should have gambled some Rutoro or Nyankole or Ruchiga, those words they understand. But some Uganda words are really far from what we know in Rutoro. Because even me, I was like struggling with this word, what exactly does it mean? But thank you so much for the explanation you have given, especially on the efficacy of the vaccine, of the malaria vaccine. I want to first of all, from the onset, tell you that in this country, 75% of the diseases that we are battling as Ministry of Health are all preventable. How are they preventable? Some diseases are diseases of lifestyle. The life we lead sometimes is not so healthy. And the others, how they become preventable is that the children are not immunized on time. I've met parents who get immunization at the time they're giving birth at the facility. They leave with a card that shows them the schedule of the subsequent vaccination. They don't go back. Sometimes out of complacence, sometimes out of carelessness, and sometimes they forget. And then you find children falling sick from diseases that would rather have been prevented. Or getting too sick and families spending a lot of money to treat them. So I thank you so much for making time to come and attend this meeting. I'm not seeing, I don't know whether there are people from Toro Kingdom. Are you here? Odingia, are you here from Odingia? And from Singawaranjuru? Thank you. Are there religious leaders in this audience? Yes. I thank you so much. So these are people who interact with communities all the time. I remember during COVID, there was a lot of talk about COVID vaccines killing people. Did you hear about it? So was it COVID that was killing people or the vaccine? Before the introduction of the vaccine, so many people died across the world. When the vaccine was introduced, COVID is now history. True or false? So how can we really tell people that vaccines are not important? The first time I got COVID, I had not been vaccinated. And you can bear me witness the young man walking out, Mr. Mohenda. 3 days I was in my house, I didn't get out. I didn't get hospitalized, you go on oxygen or anything. But for 3 days I had a lot of pain on my body. I didn't have cough or flu. But I had body aches for 3 days and they were bad. The second time I got COVID, I had been vaccinated, I didn't feel anything. I was working, but when I tested positive, I just decided to stay at home, but I wasn't feeling anything. The third time I had even got a booster, I didn't feel anything at all. So the vaccines work. But the first time I was injected with COVID vaccine, I really felt terrible. I even called Dr. Diana, I had not yet joined the Ministry of Health. I said, you guys have you vaccinated me with the poison? I feel so much pain around my body. She said, take just a Panadol. For me, I went down for a week. That's what she told me, and she's a doctor, a consultant physician, a permanent secretary. She said she went down for a week after the vaccination. So bodies react to vaccines. Even the children, remember, some of you mothers and fathers, you have taken your children for vaccination. When they come home and get a fever, and you can panic and even go back to the hospital, but the child eventually picks and is prevented from this disease. So I would like to really thank PATH for organizing these town hall meetings across the country and for your continued partnership with us as Ministry of Health. Your efforts in facilitating community dialogue, promoting health education, and supporting immunization outreach and really commendable. These engagements help bridge the gap between communities and the health systems, allowing us to listen and learn from one another. Routine immunization remains one of the most effective and life-saving health interventions available. It protects children and communities from preventable but deadly diseases such as measles, polio, diphtheria, tetanus, and tuberculosis. Now, you know that the vaccines are really important. There are some diseases we don't hear about, some words which we used to treat measles are no longer there. I remember I got measles when I was not young, not old, but I got measles in 1993. It put me down together with my sister, who was actually expecting her second born. She was even admitted. But my dad said we had been vaccinated. He doesn't know why we had measles again. But it was many years because you are immunized at 9 months. I think it was a wave of measles, but it doesn't exist anymore. I don't see many people get measles. I have children, they are now adults, all of them Gen Zs, but none of them has ever got measles. They have never got measles, they don't even know what it means. We have seen significant progress across reducing of mortality and improving overall health and outcomes across Uganda over the years. Immunization not only saves lives, it also reduces the burden of our health system by preventing disease outbreaks and long-term disability. I think you've seen people who have got, I think, cerebral malaria, and from then they become kind of vegetables. I don't know whether it causes also mental retardance. Some children who get that severe malaria may never have a proper functional brain. Or they become dead, I don't know, something like that. The government of Uganda is fully committed to strengthening the immunization program under UNEP, and the doctor explained all this. We have integrated routine immunization into our essential health service offered as part of primary health care, and we continue to expand access through outreach and facility-based services. I would also like to announce that one of our major and recent milestones in the introduction of the malaria vaccines in selected districts in the region, the malaria vaccine will be an additional malaria prevention tool and will be used in combination with existing malaria prevention interventions. Don't say my child has malaria, but my kid was immunized, so I don't have to treat this malaria. You can't treat, and as they continue finishing their doses, then they become, at least they build some immunity in their bodies. It will be another layer of protection for our children against one of the leading killers and yet preventable disease in Uganda. I hope you've already known that we lose 16 people to malaria every day. More than any other disease, even HIV doesn't kill as many people. Only COVID maybe came and swept a lot of adults, and children were safe. So, ladies and gentlemen, I pray that you put this in your mind, go back to the communities, educate them, explain to them, because vaccine hesitance brought problems to many, many people. Over the years, whoever says, oh, the vaccine is not working, but you haven't even taken it, they are the ones who actually got down under the weight of sickness. So despite our achievements in primary health care, particularly immunization, we still face challenges in ensuring every child is fully immunized in some areas. We continue to see gaps due to access barriers, vaccine hesitance, or even lack of awareness. These challenges can lead to pockets of low coverage, putting our communities at risk of vaccine-preventable disease outbreaks. The other day we had Ebola. You are even lucky that we are here. If that Ebola had not been contained, I don't even think we would be here talking. Just one person who came from Togo infected so many others, and I think you know the story. She died, her baby died, you know, and she was Muslim. The people who prepared the body to bury it got Ebola, but some of them were treated. So it's a deadly world we live in, especially us who are within the Congo Basin. We are prone to getting a lot of pandemics, so we need to be more careful and be each other's keepers. That is why community engagement is so crucial and critical. We must continue to work together. Parents, political, religious and cultural leaders, teachers, health workers, and everyone to educate and mobilize our communities to fight against diseases. I want to especially recognize the role of the village health teams and community health extension workers, the CHUs, who are the backbone of primary health care in Uganda. You are much appreciated. Thank you for your service. You render a service which has not even any pay. We appreciate the sacrifice you make to reach out to every household within the health, with the health intervention. Indeed, you are our heroes in the community health and primary health care. I call upon parents who are here and elsewhere. I know the message will reach out. And the caregivers, because some people don't have parents, to take responsibility and ensure that your children receive all their vaccines, especially the malaria vaccine that was launched at the beginning of this month. We have to ensure children who start their malaria vaccination complete all the 4 doses if we are to achieve maximum benefit from the vaccine. I want to just give you a personal experience. I got malaria in 1987 as young, got malaria, and from then I've never got malaria. And I've never slept in a mosquito net here in Fort Portal, and I've never seen even one mosquito in my house. because this place is really cold. But outside the cold areas, like if you go to Mikasese, there's a lot of malaria. But also we have a lot of crater lakes, remember? We have a lot of water bodies, which are really breeding grounds for mosquitoes, and a lot of vegetation. They are all breeding grounds. So if we can keep away from stagnant waters around our homes, overgrown grass, and also plant some grass. Doctor, you must teach people to plant some grass that protects them from malaria, especially around the houses. I think there's rosemary, the others I don't know them so well. We have rosemary around my house. I've never seen a mosquito near my home. So Califuha, I actually have Califuha as well, and a lot of it. I have never seen one mosquito in my house, and I live right opposite a great lake, right here in South. I don't get mosquitoes. So kindly sleep also under mosquito net if there is mosquitoes near you, so that you can protect our children. Let us also continue fighting misinformation of vaccines with facts and build community trust and confidence in our immunization program. Routine immunization is safe, it's free, and available at all public facilities and during outreach across the country. With assured continued support from Gavi and many others, all our partners really, WHO, UNICEF, PATH, CHAI, we continue to strengthen vaccine delivery and improve the cold chain supply systems and support our frontline health workers to reach every child with the vaccines they need. And as I conclude, I want to really thank each and every one of you for your dedication, your commitment, your time that you have given this meeting, and also the support that you give us as a health sector and the support you give to our children. Immunization is not just a health issue, it is a community responsibility. Imagine how much money you would spend when your child has malaria, yet you had a vaccine which was free and you didn't take the child for it. The kind of money you spend out of pocket expenditures to go to hospitals will be too much. Let us make this epoch count. Take your child for vaccination and encourage others to do so as well. Together we can secure a healthier, brighter future for the children of Uganda. I thank you so much for your kind attention. May God bless you.
Thank you, Minister. I think Catherine knows how to do it very well. She's getting to her seat. Let's appreciate her.
Stand up. Wow, stand up. We are going to give a sad. But it's starting with another program. How? Take it. Asante sana. Yongeza tena.
Thank you, Catherine. We take our seats. We have a part of discussion, but I want to inquire from you. Lunch is ready. Should we have lunch first? Then we come and do the part of discussion and respond to questions. So we discuss first?
Yes.
The challenge is when we discuss, we go for lunch first, the minister may not be in our discussion. So let's do a part of discussion. Briefly, we are going to give each between 5 to 7 minutes. Then we have our questions, because some questions have come from the presentations the doctor has made. Maybe you want something to ask from the minister, the director, the senior consultant of the Regional Referral Hospital. So those questions are pending. I request we do the panel. We conclude, then we go for lunch at once and go away. Thank you. Yes. Now I want to invite our panelists. I want to begin with Madam Kagabo Catherine, who is the senior health educator, Karori District. She has been with us. She has served as a health educator for great Karori, not the one including Kasesa and Ududo, but Unyangabu for Poto City. She has been our health educator, our mentor, and I think she's known very well in the ministry. I tell you, colleagues, let's welcome her, and she takes her seat as our first panelist. I also want to welcome Rudy Wilson, who is the ADHO in the local district, and he was once acting ADHO Toroko district. Mr. Rudy Wilson, you're welcome. Kindly take your seat. I also want to invite the Minister of Health, Wamba Banazuru, Wamba of the India Kingdom, sorry, of the India Wamba. Yes, of the India Wamba, the Minister of Health. Okay, she's there. I was not well fed with the profile. We mentioned the whole profile. People here have done a lot. But the Honorable Minister, you're welcome. I also want to welcome Haj Bashir. He's just fresh from Mecca. Got how many days?
3.
About 2 weeks. He was in Mecca. Haj Bashir, Ray Kayono, who is a health coordinator for the Muslim Europe region. And he's a seasoned journalist. You have had him on VOT in health programs for quite long. Kindly, Haj, take your seat. Let's send him to his seat by clapping. We expected to have an L5 Kedojo, Mr. Waihayo, whom we were unable to reach because we kept calling, the phone was on, he was unable to pick. Let's welcome the DHO, Uganda district, Dr. Obet Richard, who was once a DHO for